Morning everyone. Let us talk today on malignant connective tissue tumors. Before we start the topic, let us understand the terminology. Malignant connective tissue tumors. When you say malignant, it means that it is not benign. When you say it is not benign, it means you're talking of cancerous tumors. So these cancerous tumors, their very basic feature of a cancerous tumor is that they show high degree of pleomorphism and they metastasize and they progress into deeper areas. Now, when you say connective tissue, you have epithelial malignancies and connective tissue malignancies. So epithelial malignancies are always called as carcinomas, whereas connective tissue malignancies are called as sarcomas. So today's topic, we'll talk about sarcomas. In the sense, we are talking about malignant connective tissue tumors. Now, when you say connective tissue, what is connective tissue made up of? Connective tissue is made up of a whole lot of structures like nerve tissue, muscle, osteoid, that is bone. Then you have skeletal muscle, you have smooth muscle, you have adipose, you have nerve tissue, and you have blood vessels. Apart from that, you also have certain set of WBCs, that is, to be more precise, lymphocytes, which will cause lymphomas, a whole set of different entity. Now, fibrous tissue origin tumors are called as I told you, sarcoma. So they are called as sarcomas. Cartilaginous tumors are called as chondrosarcomas. Bone tumors are called as osteosarcomas. Lymphoids are called as lymphoma. When you say lymphoma, you're talking of a malignant lymphoblast. You're talking of a malignant lymphoblast or a lymphocyte. It is divided broadly into Hodgkin's and non-Hodgkin's. And then you have a different entity called as Burkitt's lymphoma, which is an endemic in nature. We'll talk about it when we come across. Next you have is plasma cells. In plasma cells, you have multiple myelomas and you have plasma cell myeloma. As I told you, muscle is differentiated into smooth muscle and skeletal muscle. So smooth muscle tumors are called as leiomyosarcomas and skeletal muscle tumors are called as rhabdomyosarcomas. Although for your dental BDS level, we do not talk about that. But otherwise for your BDS level, we talk about leiomyosarcoma. Then you have nerve tissue. Nerve tissue, you have MPNST, malignant peripheral nerve sheath tumor. Then you have blood vessels. In blood vessels, you have hemangiopericytoma, hemangioendothelioma, and angiosarcoma. Last is disputed origin, where you have the Ewings and the Kaposis. They are commonly called as the round cell tumors. Now, before we come across that, histopathology, before we get into histopathology, let us understand what these basic outcome or basic, the histopath of a sarcomas. We have, as I told you, you basically have skeletal muscle, smooth muscle, and nerve muscle. These three constitutes majority of your sarcomas. Now they are classified into spindly lesions or spindle cell lesions, and then you have round cell tumors. So when you talk of spindle cells, what are you talking of? You're not talking of the cell outline, but you're talking of the nucleus that is present. So for all these spindle cell tumors, when we say, we talk about the nucleus. The nucleus is spindle shape, that is, it has pointed ends. When you talk about round cell tumors, when you say, as I told you, Kaposis and Ewings, they are round cell tumors. So when you say round cell tumors, the entire histopath, the entire slide would appear as round cells which are pleomorphic, and the nucleus of course shows high degree of pleomorphism. So broadly, sarcomas can be classified into spindle cell lesions and round cell lesions or round cell tumors. We'll talk about the first spindle cell lesion, which is called as fibrosarcoma. So name itself says you're talking of fibroblasts which are malignant in nature. So this is sarcoma because it's a connective tissue. So you have malignant fibroblasts along with collagenous background. Now most of the connective tissue tumors in the head and neck region as well as other parts, you rarely come across directly a de novo. When you say de novo, meaning to say that it is freshly arising from the head and neck region. You always have soft tissue tumors or connective tissue tumors that migrate from the distant areas of the body into the head and neck region. So you always have metastasized forms of connective tissue tumors exclusively in the head and neck region. So when I say primarily central in origin, I mean to talk that these are not really associated in the head and neck region, and they are always centered along the bone. So lesion, if you say clinical features, it is males greater than females. age greater than 40 years of age. The long bones, as I told you, it is they metastasize to head and neck region. So it is, you always have your peripheral skeleton, that is your long bones, especially the long bones. You can have the tibia, the fibula, radius, ulna, then you have the femur, or you have the humerus. So these are the long bones that are commonly affected, and most of the times these are burrowing. They are very, very pathognomic. The sign is they really invade and penetrate into deeper connective tissue. So you have pain and swelling leading to destruction of bone and fracture of the entire long bone. So these are basically seen as central in origin and secondary to any kind of other metastasizing tumor. So with this clinical features, let's see how fibrosarcoma would look like. So fibrosarcoma, I just told you that these are spindly shaped lesions. When I say spindly shaped, I'm talking about the nucleus. The nucleus has tapered ends, so they resemble your spindle cells or long cells with tapered endings, and they have lot of mitotic figures if you're talking of a poorly differentiated or a highly graded tumor. Otherwise, a well differentiated tumor will always have spindle cells with tapered ends. So it is differentiated into well, intermediate, and high grade. When you say well differentiated or stage 1, you're talking about less amount of pleomorphism. Although the cells are pleomorphic, mitotic figures are not really alarming or bizarre. They are plump but highly proliferating fibroblasts with a rich collagenous stroma. Now, when you come to intermediate grade, here you have certain additions, meaning to say that the tumor progresses, so it tends to take up a lot and lot of abnormal DNA, so they become more and more bizarre. What do you say, what do you mean by bizarre? They tend to differentiate, break down, and multiply at a progressively alarming speed. So you have a lot of pleomorphism, cells undergoing different stages of cell divisions. You see cells like that, and then you have a lot of pleomorphism, and in response to this, the connective tissue starts piling up lot of collagenous stroma or lot of fibroblasts. So you see lot of hyalinization. When you say hyalinization, you see large amounts of eosinophilic areas of collagen getting deposited. Then you have moderate to severe pleomorphism, and classically you have the herringbone pattern. Herringbone pattern, all of you are very familiar. If you all eat a fish, you are familiar with the fish, and it has those fish bone which we talk of, the central area with the spikes on either sides, that is called as a herringbone. Herringbone is a type of a fish. So that is a classical feature of a moderately differentiated to a high grade fibrosarcoma. Now, as you look into these slides, you can appreciate here in the slides you have whorls. All these are, you can make out that the cells are all spindly, so they are spindly shaped lesions. You can see certain amount of whirling out pattern. The cells are getting entrapped into itself. They are forming as petals, like petals of rose petals. So they are forming lot of whorls, and then you have this herringbone pattern. You have this, you can appreciate a long spike here, one arising like this, another one coming out like this, and in the center you can see whirling out. So this is a bizarre mitotic figure or atypical mitosis, highly cellular stroma with anaplasia. What do you mean by anaplasia? Plasia or placine means to grow, ana means to move backward or no growth. So dysplasia means disoriented, anaplasia means to move backward, retrograde. So the cell, instead of acquiring adult features, it is acquiring the it is acquiring the what do you call it as fetal, or it is acquiring less amount of mature or immature features. The last in this is sclerosing epithelioid fibrosarcoma. Now, this is a very abnormal or rarely occurring tumor. If you look at the name, it says sclerosing. When you say sclerosing, there is again differentiation of connective tissue into bands of dense collagen, and then you have epithelioid cells. Epithelioid cells along with fibrosarcoma. When you say epithelioid cells, now where is this epithelioid cells coming up? See, sarcomas are always connective tissue tumors. Suppose when they invade or when they penetrate deeper, they might break down the connective tissue, make its way into epithelium, wherein certain amount of epithelial cells from the basement membrane can get entrapped into the connective tissue. So these are called as epithelioid, loid, oid. When you say oid, meaning similar to. So epithelioid cells, these are similar to your epithelial cells. Treatment for all the sarcomas are very extensive surgical excision. In fact, they just cut out and throw the tissue, followed by, that is called as radical surgery, followed by radiotherapy. These are most of the times very progressive and responsive to radiotherapy. Occasionally, especially for lymphomas, chemotherapy can also remain a choice. Now we'll talk about malignant peripheral nerve sheath tumor, also called as MPNST in short. It is, the other names of this is malignant schwannoma, malignant neurilemoma. So what is this tumor we are talking of? We are talking of a nerve tissue tumor. To be very specific, we are talking about Schwann cells. So what are the Schwann cells? Where do you see Schwann cells? Schwann cells are seen in and along the nuclear membrane. And what is neurilemoma? That's your myelin sheath, the covering of your nerve tissue fiber. So you're talking of a malignancy of peripheral nerve cells. You have central nervous system tumors and peripheral nervous system tumors. So we are talking of peripheral. Central nervous system tumors is not for your level at all. So in this chapter, we will only talk about MPNST, although you have other types of nerve carcinoma, nerve sarcomas or neural tissue tumors. Clinical features. Now this is seen in a very young population of just about second to fourth decade of life. Males are again more predominantly affected with the disease. Now persons with neurofibromatosis or neurofibroma. Neurofibroma is a benign tumor of nerve cell origin or peripheral nerve Schwann cell origin. So persons associated with neurofibroma or neurofibromatosis are more prone. Surprisingly, MPNST is commonly seen in the head and neck region than the other parts of the body, although the oral cavity per se is rarest because we are dealing with a nerve fiber. So you have your mandible, you have lot of, you have basically you have your facial nerve that comes into the head and neck region, and then you have your trigeminal nerve that comes into your head and neck region, and the branches of course will diverge all over the face. So amongst the trigeminal and your facial nerve, it's your mandibular nerve. Now mandibular nerve is a division of trigeminal nerve. Trigeminal nerve has ophthalmic, maxillary and mandibular. So it's your mandibular nerve that is most prominently getting affected by this MPNST. So pain, when you say nerve cell tumors, always remember you have paresthesia, pain and muscle weakness that runs along the course of the nerve. So radiographic feature, we are talking of a soft tissue tumor, so you hardly tend to see anything unless the tumor is burrowing into surrounding bone, wherein there is some amount of cortical plate getting eroded. That is when you might see diffuse radiolucencies, but otherwise you will not really appreciate anything on the radiograph. Now histopathology for MPNST is very classic. This is again a variety of spindle cell lesion. We just spoke about fibrosarcoma, which is one of the topmost examples of a spindle cell lesion. The second one is again a type of spindle cell lesion wherein the nucleus here, as in fibrosarcoma, we had pointed end. The ends of the nucleus were pointed, tips were pointed. But for nerve tissue tumors, the nucleus is always called as wavy or comma shaped. Few textbooks also call it as pencil sketch. Few textbooks also give it a term as pencil sketch tumors. So the comma shaped or wavy outline or comma shaped or this kind of pencil sketch nucleus is a characteristic feature of MPNST. You do not have any grading, meaning to say that MPNST are by and large and by default very aggressive tumors. So you don't see a mild MPNST. All that you come across, if at all you come across an MPNST, would always be extremely bizarre mitotic figures, extremely anaplastic tissue, and these are highly aggressive tumors. Sometimes the expectancy of life is also very short because the tumor progresses all through the nerve course and it leads to complete paresthesia, hemiplegia, periplegia, all these are the complications that you come across with MPNST. So types in this is divided into epithelioid, mesenchymal and glandular. This is not to your level of understanding, but just to tell you, or for us to finish the understanding, apart from this nerve tissue contour, that is your pencil or wavy shaped nucleus, what else that you see is epithelioid. As I told you, suppose if there is a breach in the basement membrane and if the tissue makes an entry into the epithelium, the basement membrane cells, which are epithelial cells, they might come into contact with the connective tissue, wherein you will see epithelioid like cells coming up. Sometimes if it is very close to, say, in the head and neck region, you have the salivary glands, so glands can get sometimes entrapped with, that is where you see glandular forms along with your MPNST, and mesenchymal deposits, again wherein the fibroblast in the connective tissue can get triggered because of MPNST, and then you have a combination which is called as a hybrid tumor, wherein you have fibrosarcoma along with MPNST burrowing into the deeper facial tissues or into the deeper connective tissues. Wide radical resistance, wide radical surgery, and these tumors, nerve tumors, by and large are radio resistant, so they are not subjective, or they do not respond to radiotherapy. So the choice of treatment is wide surgical excision followed by chemotherapy, provided the patient is available to take up this surgery, because as I told you, the disease is very debilitating with a high morbidity and mortality rates. We'll now talk about the third set of, again, a spindle cell lesion, wherein we are talking only about smooth muscle, not the skeletal muscle. So skeletal muscle tumors are called as rhabdomyomas or rhabdomyosarcomas. These are round cell tumors. Now what we are talking here on the slide is a leiomyosarcoma, which is a smooth muscle tumor. So where do you see smooth muscles? All your oral cavity, your the esophagus, the pharynx, the genitourinary tract, the genital tract, and then you have your intestinal tract. Most of your tissues, they are all the uterus, the prostate. All these are smooth muscle tumors. So tumors arising from smooth muscle origin. Now here again, clinical features, these are extremely painful. They are fixed to the submucosal tissues, middle age. So females are again more commonly. So that is why you have lot of uterine cancers. Yes, cervical cancers, vaginal cancers, uterine cancers. All these are very common because it's the uterus that gets affected. So middle-aged women, exceedingly rare in the oral cavity. You hardly tend to see anything. If at all you see, probably the cheek, buccal mucosa, that can be more pronounced, or you can probably see a metastatic leiomyosarcoma migrating from a distant site into the cheek region in the orofacial areas. Histopathology, you will again here see cigar shaped or blunt end. So we spoke about three type of morphological features of a nucleus. If you have pointed or a spindle shaped nucleus with pointed ends, then you're talking of a fibrous tumor. If you're seeing a wavy or a pencil sketch or a comma shaped nucleus, then you're talking of a nerve tumor. If you're seeing blunt end or cigar shape like your cigarettes, then you're talking of leiomyosarcomas. Now mild atypia, hyalinized stroma, and these again, the mode of treatment is wide surgical excision. Otherwise it is called as panhysterectomy, wherein the uterus along with the fallopian tubes and the ovaries, everything is taken out in one knock. So we completely take out the entire genitourinary tract of the female. And these are again resistant to radiotherapy and more prone for, or they show positivity for, chemotherapy. Next, we talk about a different set. So we spoke about fibrous lesions. In fibrous lesions, we had fibrosarcoma, we had leiomyosarcoma, and we had malignant peripheral nerve sheath tumor. Now we'll talk about cartilage. Cartilage is called as chondroid areas. So cartilaginous tumors are called as chondromas, and their malignant counterparts are called as chondrosarcomas. So chondrosarcomas are malignant cartilage producing tumors. tumors. Now this you can definitely see in the head and neck region, because if you remember your first BDS bone chapter, we had endochondrial type of ossification and intramembranous type of ossification. So because you see cartilage in the maxilla as well as in the mandible, you can expect chondrosarcomas in the head and neck region. Most of the times mandible is a compact bone. Amongst the maxilla and mandible, if I ask you which is more stronger and sturdier, obviously it's the mandible. It's a single unit made up of rich, dense, compact bone, whereas your maxilla is made up of intramembranous ossification, and it has union of two palatine shells. So it is a cartilaginous bone. So slow growing tumors, you can have large areas of ossified, calcified or myxomatous areas. Clinical features, it can be seen in any age group. Males are greater than female. These are high grade tumors and they show severe pain. Low grade can sometimes be seen, but otherwise like your MPNST, these are extremely aggressive tumors that penetrate into deeper connective tissue. Now you have mesenchymal chondrosarcoma, clear cell chondrosarcoma, and dedifferentiated. Let's go with one by one. When you say mesenchymal, then you're talking about connective tissue that includes either your glandular, it can include fibroblast, it can include nerve tissues. So that is where you can call it as mesenchymal. When you say clear cell chondrosarcoma, the cytoplasm is clear. From first BDS till now, I have been telling everybody who comes to me that do not draw a cell without cytoplasm. In your language, pink has to be present inside a cell. A cell without pink or cytoplasm is a malignant cell. So that type of cells are called as clear cells. So clear cell chondrosarcoma, when I say, it means that how should a chondroma look like? If you remember, you must have drawn in your anatomy first BDS, you have lot of bluish appearing binucleate cells inside a lacuna. So this is how a chondroblast or a chondroid tissue would look like. When you say clear cells, you will only put the dot, but in your language, you will not fill the cytoplasm with your pink. Your chondroblast or chondroma are always bluish tumors. They are more myxoid tumors. Why? Because they have lot of glycosaminoglycans and they have lot of chondroitin sulfase. These are secreting tumors. So when they ossify, then they become into pink or ossifications wherein chondroitin sulfate gets deposited. So clear cell chondrosarcomas are slow growing. They have a high cure rate, and dedifferentiated is the most aggressive and malignant form with a very low cure rate. Now oral manifestations, as I told you, you can see that it is maxilla that is most commonly involved. Extensive lesions, expansive regions, bone destruction, expansion of jaw bones are also very common. So this is how a chondroma would look like, or chondrosarcoma would look like. You can see generally a chondrocyte is binucleate. So this is your lacuna and you have two cells, but now you can see it's a monolocular lacuna with a single nucleus. Again, you can see this is large cell with nucleoli bubbling out, and then you can see small cells. And look at the stroma, it is not appearing more as bluish, it is appearing more as pinkish. So it is getting ossified here. So this is how your malignant chondrosarcoma, and this is an OPG. Very not characteristic sign. Suppose if I tell you that this is a periapical radiolucency, you will still say yes. You will not argue with me, because you can only see that the cells are monocular, or the radiolucency is underlying to the root apices. So low grade is more difficult to diagnose. You have plump nuclei, more than 2 nuclei. You have conventional chondrosarcomas, secondary chondrosarcomas, and peripheral chondrosarcomas. So conventional chondrosarcomas are divided into borderline, low grade, and high grade. Secondary chondrosarcomas they exist from a pre-existing tumor, benign tumor, which can be fibrous dysplasias. It can be an extraction socket, or it can also be from a post-radiation site. And peripheral clear chondrosarcomas, these are clear cell in origin. They can have mesenchymal, or you can have a dedifferentiated chondrosarcoma. Gradings, the larger the grade or higher the grade, more is the pleomorphism, more is the poor is the chances of survival, and mortality rate is also higher as the grading moves. So you have grade 1, grade 2, and grade 3 chondrosarcomas. So with this, we will stop here for today. We will continue with osteosarcoma tomorrow. We have discussed about fibrous lesions and we have discussed about myxoid areas, that is chondrosarcoma. So we discussed about fibrosarcoma, malignant peripheral nerve sheath tumor, leiomyosarcoma, and then we discussed about the fourth lesion, that is chondrosarcoma. So you have to remember herringbone pattern. It can come as a viva question. You also have a slide. So herringbone pattern is one characteristic feature of fibrosarcoma. Chondrosarcoma, it will not have the regular binucleate pattern. And then the cigar-shaped nucleus is a characteristic feature of leiomyosarcoma. Comma or a wavy or pencil sketch nucleus is a characteristic feature of nerve sheath tumors.